Welcome to Chapter 8, the xanthines. This is an interesting group of medications. There's not many to it, but we're still trying to also figure out what do these guys really do for us. So we're going to talk a little bit about xanthines. Why do we use them? What are the clinical indications of them? The different theories of why they happen and why they work. Are they toxic? And the answer to this is yes, very toxic. They have a very narrow therapeutic range we're going to take a look at. Once you get out of that range, it's either on the low side not going to work, on the high side can cause a lot of different issues for us. And then when do we use them? What is the major reason for using them? We see that more with apnea of prematurity than we do with adults or even with kids in some cases. So basically, they're easy. We use them for the management of asthma. We also use them for the management of COPD and then the apnea of prematurity in neonates. It is not a first-line drug for asthma or COPD. Matter of fact, it's somewhere around the third or fourth line for the most part. Patients who take xanthines either love them or hate them. There's no in between as far as that goes. So it's really kind of interesting when we talk about them. Apnea prematurity, we do use them, and it sometimes is a first-line drug for the children that have that. So some of the clinical indications, you can see I've just differentiated for them, okay? Sustained release theophylline is indicated as an alternative for maintenance for your mild persistent asthma and higher in patients older than 5 years. I'm not going to give it to you if you're less than 5 years old, okay? And then it's also an alternative to step 3 and higher for those patients older than 5. And there you can see it has a very narrow therapeutic index. This narrow therapeutic index is what makes this not as effective as we would like them to do. The problem with these, theophylline is affected by different foods and drugs and other things too. So we can take that narrow therapeutic index and really take it out of the range fairly quickly. With our patients with COPD, the Global Initiative, or the gold standard, states that these bronchodilators are much, much better than theophylline is. It's recommended as an alternative to your beta agonist and anticholinergics. The thing about these are not rescue drugs. These are not used in acute exacerbations at all. And there you can see for your apnea of prematurity, your methylxanthines are considered a first-line agent of choice. We've used a lot of theophylline, but now we're using caffeine. Caffeine is really kind of interesting because caffeine contains theophylline, so does chocolate and things along that line. I remember even before I got into respiratory, reading an article that if you went on a camping trip with your buddy and your buddy had asthma or COPD, they forgot their medication, they're starting to have some issues with it, brew them a strong hot cup of coffee, have them drink it because the caffeine will help relax until you can do something else to take care of them at that particular point. So some of these specific agents, these are also known as methylxanthines. You're going to hear that on occasions. We find them in tea leaves in addition to the coffee, the coca seeds, the beans, and there you can see the coffee beans and the tea leaves again for the caffeine. So some of the general properties of these medications and the effects they have on humans. One of the things, if you look in your book, Table 8-1 lists some of the different agents, and 8-2, the differences between caffeine and theophylline. You guys know if you have caffeine, it does improve your central nervous system stimulation, keeps you up at night. They tell you don't drink caffeine late in the evening. Well, the same thing happens with theophylline. You also have some cardiac muscle stimulation. If you have AFib or some different dysrhythmias, they'll sometimes tell you cut back on your caffeine because that's where part of the problem could be. They're both diuretics. They have some smooth muscle relaxation. It's the smooth muscle relaxation that gets theophylline classified as a bronchodilator, okay? The thing you need to remember, though, it is not a rescue drug. It does not rescue anything. You also have peripheral coronary vasodilation, and cerebral vasoconstriction. And sometimes you'll have these used in remedies. I think Excedrin at one time had quite a bit of caffeine in it, or one of those major drugs that were out there on the market. So some of the things we see, there's different attachments, as you can see with these. There's your enhance your bronchodilation and increase your side effects, which is really not what you want. Caffeine, for the most part, decreases bronchodilation, even though we still tell folks to drink it until they get to the hospital or something. And then you have diphenylene, which is a derivative of these two, and it weakens bronchodilation too. So the major one we give our patients really is theophylline. So how does it work? It's anybody's guess. We used to say that it was a phosphodiesterase inhibitor. Does it inhibit phosphodiesterase? The answer is yeah, we think it does, okay? Phosphodiesterase is one of those substances that breaks down CAMP, 3,5-CAMP or CAMP, and that's where you get your bronchodilation from. So what we're doing with the theophylline is we're inhibiting that phosphodiesterase so that we don't stop the bronchodilation. Is it an antagonism of adenosine? Adenosine is another thing that's going to cause us some issues. Does it improve catecholamine release? We think so, but we're not terribly sure. So if anybody should ever ask you, is theophylline a really good drug? Well, take your pick. It could be or it could not be one. So what you have to do is always titrate these doses, okay? Because they're affected by the person, they're affected by what the person's doing, they're affected by what the patient or person is eating. So we have to try to figure it out. Interesting, talking with somebody who had taken this, they would tell you they would take their dose in the morning and then they would have this little cloud that followed them while the medication was working. How do they know that the medication stopped working was when the cloud went away and the sun came back. So there's different ways to tell that your theophylline is working or not working. As I mentioned before, patients love it or patients hate it, okay? So here's your different serum levels. Anything less than 5 micrograms, we don't see anything. Somewhere between 10 to 20 is the therapeutic range. Anything above 20 is nausea. Anything above 30 is cardiac arrhythmias. Anything above 40 or 45 are seizures, okay? One of the things you don't want to watch is somebody having a seizure. For asthma, we look at the therapeutic range somewhere between 5 to 15 micrograms per ml. COPD, we're looking for 5 to 10 micrograms per ml. And this has to be tested. They have to do what's called trough levels, and these trough levels tell us what you have. So it has to be titrated, okay? We have to either go up, down, or you can sometimes stay where you are. But it has to be adjusted for children. If you're in CHF, if you have liver disease, okay? It has to be guided by the clinical reaction of the patient or the trough levels that you're doing at this particular point. So unfortunately, if you cannot get this, then what you have to do is figure out how's the patient reacting to it, okay? When you're doing your blood levels, they have to be taken at the time of peak absorption. This is 1 to 2 hours for immediate release, 5 to 9 hours after morning dose for sustained release. And so we have to watch and see what's going on with it. So there it is, rapid theophylization, 5 milligrams per kilo of lean body weight. There's your loading dose for that one, and then the slow titration for the longer term ones. So what are some of the toxicity and side effects? Again, I have to tell you, it's a narrow therapeutic margin, and you can go out of this fairly quickly, okay? And so there it is, distressing ones will occur at therapeutic level, but more likely when you're out of it, okay? So we can see gastric upset. So if you have a peptic ulcer or acute gastritis, you don't want to do this. Headache is another one. We use it to treat headache. It can cause a headache. You can become anxious. You can have a lot of diuresis going on. It can affect your liver, your kidneys. It interacts with other drugs. We know it interacts with most antibiotics. You get a synergistic effect. And if you guys remember, synergism is your 1 + 1 = 3. So what your physician has to do, or whoever's ordering this for you, has to cut back both of these drugs, because by cutting them back, you may get the desired dose that the physician wants. Okay, so you got to watch that. Another thing that we have to watch is your beta agonist, because it has an additive effect with theophylline. So we have to watch and make sure that we don't have problems with it. So here you can see just a few conditions that increase it: viral hepatitis, left ventricular failure. What decreases it? Smoking. People who smoke have to understand that that's going to have an issue with it. So we have to watch that too. So basically, again, this is not a first-line drug. This is not the first drug we're going to. We're going to go back to your bronchodilators. We're going to go back to your parasympatholytics. We're going to go back to anything else before we start to pull this into the regimen at that particular point. So other things that it can do for you, though, so there always has to be something good to balance it out. It can increase the force of the respiratory muscle contractility. It can increase respiratory muscle endurance. It increases the ventilatory drive. Cardiovascular effects: increases the cardiac output. Decrease pulmonary vascular resistance, so you get better blood flow. And it does have some anti-inflammatory effects. These effects, though, are not enough to put it on a first-line bronchodilating effect. With apnea prematurity, it is a first-line drug, and you can see that we prefer caffeine over the other ones, and there's a lot of stuff that's in your book. This is something put on the back burner, because you're going to see this again when you take perinatology. So before we administer these, we need to know how effective is it for that patient. If you go in there and the patient goes, "I hate the drug, I can't take the drug, I refuse to take the drug," there's probably a good possibility that patient's not going to want that drug. Okay. Remember, you have to monitor your flow rates with your bedside peak flow meter. Bring it with you if you want to, but don't, because you'll probably lose it. We can do this with a portable spirometry. You guys were doing that last week. You can do pre and post bronchodilator studies. We know about how much reversibility we're going to get. And then we have to do a good patient assessment. Good patient assessment before and after vital signs, breath sounds, all of those different things on occasions, because if you have the opportunity to stay with that patient, you want to check it out. If this patient starts acting a little strange, like they're having problems with their breathing, you need to figure out what's going on with them. You need to listen to them and then make sure all that stuff is documented and passed on to the nurse and the physician. Okay? And then if we're not sure what's really going on, now we can go ahead and get the blood levels. So there we talked about just a little before that. Look at that patient, see what's going on with them. You have to watch your patient. You have to do a good assessment. If anything, when you leave the school with your degree and you get your license, you have to know how to assess. Assess, assess, assess. If you cannot assess a patient, you cannot treat those patients. It's vitally important. We can look at their arterial blood gases. We can look at their pulse oximetry. We can just see what's going on with them. Let's take a look at these patients. You know, if you suddenly start turning a little bit on the side of blue, that is not a good color ever. Gray is even worse. So long term, what do we want to do with these? Monitor your pulmonary function tests and studies. Educate people how to use their peak flow meters. Tell them this is not a drug that's going to help you in a long term necessarily, because it is not a bronchodilator. Don't go run and grab your xanthines if you're having problems with your breathing, okay? It has systemic effects. Why does it have systemic effects? Because we either give it by tablet or we give it by IV. That is systemic effects, okay? This is not inhaled. They were looking at, I'm not quite sure where they are, the manufacturers at this point in time, but they were trying to come up with one that could be inhaled. I'm not quite sure if that's going to help us either. But right now, you are going to get ahead and get a lot of systemic effects. And then again, watch these patients. What's going on with these patients? If these patients are getting a lot of side effects and things like that, or no relief, either the level is too low or the level is too high. And these patients have to be educated what you can and cannot do, what's going to affect this and what's not going to affect it. Then we need to watch and make sure if they have CHF, liver disease, anything else that goes on at this particular point, this is going to affect the level of the theophylline in the body. And as a reminder, if you are on antibiotics because you got sick or something and you're taking theophylline, we need to remind them you cannot take both therapeutic doses because you're going to get that synergistic effect.